Here's a startling number for you. In 2017, nearly 750,000 people in the U.S. were living with end-stage renal disease.
Wow.
Yeah, and the cost to Medicare alone, it topped $35 billion.
That's staggering. It really highlights what we're talking about today.
Exactly. So let's dive right into what keeps many of these individuals alive. Hemodialysis access.
Indeed. Reliable access is absolutely fundamental for patients with ESRD to get that life-sustaining dialysis. And, well, as those figures show, it's a massive healthcare challenge, both, medically and financially.
So in this deep dive, we're tackling hemodialysis access head-on. We've been digging through some essential chapters from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition.
Good source. Very comprehensive.
Right. Our goal here is really to cut through the complexity, give you a clear understanding of the key considerations, the strategies for making these accesses work best. Think of it as getting the crucial insights without having to, wade through the whole textbook yourself.
And what makes this topic particularly interesting, I think, is how our understanding and the approaches have really changed over time. It's a field where knowledge is constantly evolving, and the textbook really reflects that whole journey.
Absolutely. And the need is just clearly growing. We're seeing an increasing number of people with chronic kidney disease and end-stage renal disease, largely driven by, well, an aging population and, sadly, rising rates of diabetes.
Yeah, the 2017 data, it reveals that while the rate of new ESRD cases kind of surged back in the late 20th and early 21st centuries, it leveled off, peaked around 2006, even slightly declined. But the total number of individuals living with ESRD, it keeps climbing, roughly 20,000 more people each year.
20,000 a year. That sustained increase, it naturally puts a huge burden on our healthcare system.
Huge.
And the financial implications are massive. Like we said, billions are spent. And the text highlights that a significant chunk of this happens during that critical transition, from chronic kidney disease to ESRD, often linked to using temporary catheters. Complications with newly placed permanent accesses. It just leads to more interventions, more hospital stays.
Yeah, and if you look at the bigger picture, successfully navigating that transition, getting a well-functioning permanent access in early, it has profound implications, both for the patient's well-being and, honestly, for the overall cost-effectiveness of their care.
Which brings us to what the text calls the central aim. The right access for the right patient at the right time.
Exactly. That phrase really captures the goal.
I like how that emphasizes a really personalized strategy. The book also mentions this concept of an ESKD life plan.
Oh, yes, the life plan. It's basically a comprehensive long-term roadmap for a patient's dialysis and access needs looking ahead.
It kind of prompts the question, though, how did we get here? To this emphasis on individualized care.
Well, there's a significant history there. Lots of initiatives, guidelines, all aimed at improving outcomes in hemodialysis access over the years.
Right. The book details the National Kidney Foundation Dialysis Outcomes Quality Initiative, NKF-KDOQI. That started back in 1997, right?
That's the one. Their primary goal then was really to push for more autogenous AV accesses, using the patient's own veins.
Yeah.
The initial targets were 50% for new patients and 40% for all prevalent dialysis patients having that kind of access. A real landmark initiative.
And it's interesting seeing how those guidelines have evolved since then.
Definitely. While the long-term advantages of using a patient's own vessels have always been recognized, the focus has become much more refined. We realize that a sort of one-size-fits-all approach isn't always the best path forward.
Exactly. Then came the Centers for Medicare and Medicaid Services, CMS, with their National Vascular Access Improvement Initiative around 2003. And then the Fistula First Breakthrough Initiative Coalition a couple of years later. That Fistula First campaign really hammered home the message.
And it worked, to a point. It had a tangible effect. By 2005, the national rate of autogenous access did hit that initial KDOQI target, 40% prevalence. It kept climbing, eventually plateauing around, 60% by 2011? That was a significant achievement, no doubt.
But the text points out a crucial insight from that plateau, doesn't it?
It does.
It seems that aggressively pushing for autogenous access in every single patient, even maybe those with less than ideal veins, it might have inadvertently led to an increased reliance on central venous catheters in some cases, sort of an unintended consequence.
Which is exactly where the Fistula First Catheter Last Workgroup Coalition came in, around 2015. Their current objectives reflect this more nuanced understanding. They're aiming for 68% autogenous AV access, and this is key specifically in appropriate patients, and also aiming to get long-term catheter use below 10%. That shift in wording to appropriate is really important, highlights the move to a more tailored approach.
That makes perfect sense. It's not just about the theoretically ideal access, but what's realistically the best, safest option for that specific person. The Society for Vascular Surgery, the SVS, they also played a vital role, didn't they, shaping best practices?
Absolutely. They recognize the surgeon's critical role. So they launched initiatives like the Committee on Reporting Standards back in 2002. That was huge for establishing consistent definitions, reporting metrics. You need everyone speaking the same language.
Right.
And then came their comprehensive clinical practice guidelines in 2008. Covered everything: timing of referral, surgical strategies, managing failures, the whole spectrum.
So, okay, ensuring successful access isn't just the operation. It starts much earlier, with getting the patient to the surgeon at the right time. When should a patient ideally be seeing a vascular access surgeon?
Well, both the NKF-KDOQI and the SVS guidelines recommend referral when a patient's GFR, that's glomerular filtration rate, a measure of kidney function, drops below 25 millimole. That level indicates a pretty significant decline, and it signals, okay, time to start planning for dialysis access.
And once they're referred and evaluated, the timing for actually creating the access seems to vary. Depends on whether it's a fistula using their own vein or a prosthetic graft.
Precisely. For an autogenous fistula using their own vein, the aim is to create it more than 6 months before dialysis is likely needed. This gives it enough time to mature, for the vein to enlarge and strengthen enough to be used reliably.
Okay, 6 months lead time.
Right. Prosthetic grafts, on the other hand, don't need that long maturation period, so they can be placed closer to the start of dialysis, typically maybe 3 to 6 weeks beforehand.
That longer lead time for the autogenous access must be pretty important then. The book even mentions some compelling data on the benefits of placing it early.
Oh, definitely. Placing an autogenous access more than 4 months before starting dialysis has been linked to a significant drop in the risk of both sepsis and death, compared to placing it less than a month before, or even worse, after starting dialysis with a temporary catheter.
Why is that?
It's largely attributed to minimizing the need for those central venous catheters. They just carry a much higher risk of infections and other complications.
It's concerning then that the data suggests only about a quarter, maybe 25% of hemodialysis patients actually start treatments with a permanent AV access ready to go.
It is concerning, and the text cites some research. Lenz and colleagues, I believe, they highlighted factors like inadequate pre-dialysis care. Sometimes patients get acutely ill and need dialysis urgently, and even challenges with, patient adherence, making appointments.
So it really underscores the need for early identification, good patient education about their options, and just a coordinated care pathway.
Absolutely, to ensure timely placement of permanent access whenever it's feasible.
Okay, so let's say a patient is referred on time. What does that initial evaluation look like? It sounds like it needs to be pretty detailed.
Oh, extremely thorough. The textbook really stresses this. A complete evaluation of both the arterial, the inflow, and the outflow systems in the arm is fundamental. Maximizes the chance of long-term success. And it starts, as you'd expect, with gathering a detailed medical history and doing a comprehensive physical exam.
What specific things are they looking for in the history?
All sorts of things. Which arm is dominant? Any history of 5E lines? Central lines in the arms or chest, that's a big one. Any previous access attempts? Trauma or surgery to the arms? Underlying conditions like diabetes, peripheral artery disease, and of course, a full medication list.
Okay, and the physical exam, what does that involve?
Careful checks. Feeling the pulses brachial, radial, ulnar, in both arms. Doing the Allen test to make sure blood flow to the hand is good even if one artery is used. And then meticulously examining the superficial veins. How big are they? Do they pop up nicely when a tourniquet is on? Any signs of old clots or damage? They also look for subtle signs of potential problems higher up, like in the central veins, things like prominent veins on the chest, arm swelling.
Got it. And beyond that general H&P, there's a more focused medical assessment too, right?
Yeah.
Looking at specific patient factors that might affect how well the access works long term.
Yes, exactly. Factors like the patient's age, their sex, whether they have diabetes, peripheral vascular disease, if they smoke, that's crucial, BMI, parathyroid hormone levels, hemoglobin, and their medications. Now, interestingly, the evidence is a bit mixed for some of these, but the clearest data suggests that age, diabetes, PVD, smoking, and also hyperparathyroidism and anemia can all negatively impact how long the access lasts. Sex and obesity. The evidence there isn't as consistently significant.
Age seems like a big one to consider. I imagine that might influence the choice of access type or even where they put it.
It certainly can. The book discusses a meta-analysis that found, for instance, a higher failure rate for the standard forearm fistula, the radiocephalic in older patients. But on the flip side, they noted better patency, better function with upper arm fistulas like the brachial cephalic in the elderly.
So maybe start higher up in older folks.
It suggests that, yeah, for older individuals, especially if their forearm veins aren't great, maybe an upper arm fistula or even a prosthetic graft might be a more reliable first choice than trying that distal forearm fistula.
And diabetes. That's so common in patients with kidney disease. How does that play in?
Unfortunately, diabetes can negatively impact patency, likely due to the accelerated hardening and narrowing of the artery's atherosclerosis that often happens. Studies show a higher risk of both clots forming in the axis and something called arterial steal syndrome.
Steal syndrome.
Yeah, where too much blood flow gets diverted into the fistula and away from the hand, causing pain or numbness.
Oh, okay.
So in patients with diabetes, surgeons often try to create the fistula using the most distal artery possible, the one furthest down the arm, to minimize that risk of steal.
Smoking. We know it's bad for blood vessels generally. I assume it's bad here too.
Absolutely, no question. The text is clear. Smoking significantly bumps up the risk of both early failure, like it doesn't mature or clots right away, and late failure, where it stops working down the road.
So quitting is essential.
Strongly recommended. Getting patients into tobacco cessation programs before access placement is really ideal.
Medications seem like a more complicated piece of the puzzle, though.
Yeah.
You mentioned conflicting results.
That's right. Research looking at common meds, ACE inhibitors, calcium channel blockers, aspirin, warfarin, antiplatelets, ARBs on access patency. It's yielded inconsistent findings. Some studies suggest a benefit, others don't. So right now, there isn't really a strong consensus on whether these specific drugs consistently help or hurt long-term function. Still an area of study.
Okay, so after the history, the physical, the medical assessment, the next step is looking directly at the arteries and veins in the arm they might use, right? Using imaging.
Yes. For the arterial assessment, if the physical exam raised any flags, weak pulses, history of vascular disease, they might do non-invasive tests. Things like segmental blood pressures, duplex ultrasound imaging, pulse volume recordings, looking for significant narrowing or blockages. Ideally, you want no major pressure difference between arms, artery diameter at least 2.0 millimeters, and a patent palmar arch in the hand, ensuring good flow even if they use the radial or ulnar artery.
And if those tests do show something concerning?
Then the surgeon might think about a different access location, or getting more detailed pictures with an arteriogram. That involves injecting contrast dye into the arteries and taking x-rays. It shows blockages really clearly.
But contrast dye can be tough on kidneys, right? Especially in these patients.
Exactly. That's the trade-off. In patients nearing dialysis or already on it, the risk of kidney injury from the contrast has to be weighed carefully against needing that detailed info for successful access. They often use renal protective measures, fluids, sometimes other agents, though the evidence for some beyond just hydration isn't always super strong.
And the venous assessment seems just as critical, maybe even more so, for planning an autogenous fistula.
Absolutely crucial. If the veins aren't easily seen or felt, or if there's a history suggesting damage, then duplex ultrasound vein mapping is the standard. It's non-invasive, uses sound waves, and gives a detailed look at the vein's diameter, how well it expands under pressure, its distensibility, and confirms it's continuous, no blockages. The book cites several studies looking at minimum vein diameters needed for successful maturation. Thresholds reported range from, say, 2.0 millimeters up to 3.0 millimeters. Bigger is generally better.
And they also need to look out for narrowing higher up in the chest veins, central venous stenosis.
Yes, definitely. Clinical signs like prominent chest veins, arm swelling, a difference in arm size, or a history of central lines or multiple accesses on that side, those should raise suspicion. If suspected, a deep venous duplex of the arm and chest is usually next. If that looks suspicious, a venogram, the contrast X-ray for veins, might be needed to pinpoint the problem.
Same contrast concerns apply there too, I assume.
Same concerns. Weighing risks and benefits using protective measures. A study mentioned in the text compared duplex versus venography for detecting central stenosis. Each has its strengths.
Okay, so after all that really thorough evaluation, the team finally gets to the crucial decision: picking the best type and location of access for that specific patient. Sounds very strategic.
It is. Like we said earlier, the guiding principle is individualized access. Right access, right patient, right time. That ESKD life plan concept really emphasizes considering everything, not just the anatomy, but the patient's lifestyle, preferences, support system, long-term needs.
And for patients who are good candidates for permanent AV access, there are some general principles guiding the choice.
Yes, several key ones. First, upper extremity, the arm is preferred over the leg. And typically you start with a non-dominant arm if possible. Save the dominant one.
Makes sense.
Second, place the access as distally as possible furthest down the arm. This preserves the veins higher up for potential future accesses if needed. Think long-term.
Right. Save your options.
Third, if it's anatomically feasible, autogenous access using their own vein is always attempted before using a prosthetic graft. Why? Superior long-term patency, fewer complications. It's just generally better if it works.
Okay. Autogenous first.
And finally, within autogenous options, there's a kind of pecking order. Direct artery-to-vein connection first, then maybe venous transpositions where the vein is moved, and then more complex venous translocations.
Got it. Let's break down some specifics. Forearm access, it sounds like the cephalic vein on the thumb side is often the go-to starting point for an autogenous fistula.
That's right. The cephalic vein is often preferred for the first attempt in the forearm. It's usually pretty superficial, more lateral, so the surgery might be less complex. Depending on the nearby arteries, it can be connected at different spots. Sometimes a tiny branch of the radial artery near the wrist, the snuff box fistula, or more commonly the distal or proximal radial artery itself, sometimes even the ulnar or brachial artery. You go as distal as you can with good inflow.
So a few different hookup options just with that one vein.
Exactly. If the snuff box artery works, great, less invasive. If not, the standard radial cephalic direct connection, the classic Brescia-Cimino fistula, is next. If the vein's a bit small or deep, maybe a transposition to bring it closer to the skin. And if the distal arteries aren't good enough, you might move up to the brachial or proximal radial and create a looped fistula within the forearm.
What if the cephalic vein just isn't suitable? Is the basilic vein on the pinky side the next option?
It often is, yes. The basilic vein in the forearm is a common alternative, but its location more medial, often deeper, means it almost always needs a surgical transposition. You have to surgically move it closer to the skin surface so it can actually be cannulated for dialysis.
Okay, so basilic usually means transposition.
Usually. It can be connected to the radial, ulnar, or brachial artery for inflow, again, aiming for the most distal suitable artery. So a radial basilic transposition or ulnar basilic transposition would be preferred. If those distal arteries aren't good, then maybe a more proximal looped transposition using the radial or brachial artery. You can't really use that tiny snuff box artery for the basilic vein, though too far apart.
The book also mentions using veins from the leg, like the femoral or saphenous, and moving them to the arm. Sounds complex.
It is complex. Those are alternate vein translocations, definitely an option when the forearm cephalic and basilic veins are out. But the 2019 KDOQI guidelines acknowledge these are technically demanding more extensive surgery, potentially higher complication rates. So for many patients in that situation, maybe a prosthetic graft in the arm or a long-term catheter, or even thinking about peritoneal dialysis might be a better fit. It's a case-by-case decision. The book has a whole chapter on these complex accesses.
Okay. So if there are no suitable veins in the forearm for an autogenous fistula, then we start talking about a prosthetic graft in the forearm.
That's typically the next step, yes. If the native veins aren't adequate, a prosthetic graft, usually EPT-FE, is considered. These can be connected to the distal or proximal radial artery or the brachial artery. Again, aim for the most distal arterial connection possible. A common setup is a straight graft from the radial artery near the wrist up to a vein near the elbow. Or, if needed, a looped graft using the brachial or proximal radial artery connecting to a vein higher up in the forearm.
Now, there seems to be some debate here. If you've used up all the autogenous options in the forearm, what's next? A forearm prosthetic graft, or jump straight to trying an autogenous fistula in the upper arm?
That's a really key clinical question, and there's no single right answer. The book emphasizes this needs to be a shared decision, part of that ESKD life plan discussion. You have to consider the patient, their overall health, and crucially, how good are the veins in the upper arm? Are they suitable for a fistula up there?
So if the upper arm veins look good,
Yeah.
maybe skip the forearm graft.
Yeah. That might be the better long-term strategy, yes. If a forearm prosthetic is chosen, it should perhaps be seen as a bridge, a temporary step maybe, until an upper arm autogenous access can be made later. And importantly, the experts advise against too many heroic attempts to salvage a failing forearm prosthetic graft with balloons and stents.
Why is that?
because those procedures can damage the outflow veins higher up in the arm veins you might need later for that upper arm fistula. So protect those proximal veins, plan for eventual conversion if possible.
Got it. Okay, let's move up the arm then. Upper arm access options. Same principles apply. Autogenous first, if possible.
Very similar principles, yes. After exhausting forearm options, you look at the upper arm. The cephalic vein there is again the preferred autogenous choice if it's suitable. Arterial inflow typically comes from the proximal radial artery just below the elbow, or the brachial artery itself. If the vein and artery line up nicely, a direct connection works. If the vein is too deep or far away, a transposition is done to bring it closer to the skin for needling.
And if the upper arm cephalic vein isn't good enough, what's the next autogenous choice?
Then you look at the basilic vein in the upper arm. Similar to the forearm, the upper arm basilic is more medial, often deeper, running under muscle. So it almost always requires a surgical transposition to make it accessible for dialysis. It's a bigger operation than a cephalic transposition, usually. Arterial inflow comes from the proximal radial or the brachial artery.
And again, if neither upper arm cephalic nor basilic vein works, are there other native vein options, like translocation?
Yes, similar to the forearm, there are less common options, translocating the brachial vein itself or bringing up veins from the leg. But again, these are complex, higher potential morbidity, maybe less certain long-term patency. So often in these challenging cases, an upper arm prosthetic graft or a catheter or another dialysis modality becomes a more practical choice. That complex access chapter covers these too.
Right. So if all autogenous upper arm options are exhausted, then it's time for an upper arm prosthetic graft.
That's correct. If no adequate native vein is available, an upper arm prosthetic graft is the next option. Connected to the proximal radial or brachial artery, tunneled under the skin, usually up to a vein in the axilla, the armpit, or high in the upper arm. Can be straight or slightly curved.
Okay. Regardless of type or location, autogenous, prosthetic, forearm, upper arm, are there some common surgical technique principles? Especially for autogenous fistulas.
Yes, definitely some core principles. For autogenous fistulas, you carefully cut the distal end of the vein, flush it with heparinized saline checks its size, any blockages, side branches. If transposing, you fully dissect and mobilize the vein, tying off significant side branches to direct flow into the main channel. The arteriotomy, the hole in the artery, is kept relatively small, maybe 4 to 6 millimeter max. Why? To minimize that risk of arterial steal syndrome we talked about?
Right. Don't want to steal too much blood from the hand.
Exactly. Flush the artery too, prevent clots. The connection itself is usually end of vein sewn to the side of artery. This might reduce venous pressure downstream. Use fine, non-absorbable suture, continuous stitch, helps prevent the connection from dilating too much over time. And for non-transposed fistulas, sometimes you tie off large vein branches near the connection to really encourage flow up the main channel you want to develop.
The book also mentions doing transposed accesses in one stage versus 2 stages. What's the difference there? Pros and cons.
Good question. One stage means doing it all at once. Create the artery-vein connection and transpose the vein in a single operation, single anesthetic. Advantage. One surgery, one recovery. Disadvantage. If the fistula then fails to mature or clots early, you've done a big operation for nothing, essentially.
Okay, makes sense. What about 2-stage?
2-stage involves first just creating the direct artery-vein connection. Then you wait maybe 4 to 6 weeks, let the vein start to mature, dilate from the increased flow. If it looks like it's maturing well, then you do the second operation, the transposition surgery itself.
So you confirm it's likely to work before doing the big transposition part.
Exactly. That's the benefit. Ensures the vein has maturation potential before the extensive dissection. And the dissection might even be easier on a slightly matured vein. Downside. Obviously, 2 surgeries, 2 anesthetics. The textbooks suggest maybe considering 2 stages, particularly if the vein is quite small to begin with, like less than 4 millimeters maybe.
What about placing prosthetic grafts? Any key differences in technique compared to fistulas?
Some key differences, yes. The arteriotomy length isn't as critical because the graft diameter itself limits the flow and steal risk. But you still flush the artery carefully. Usually use a 6 millimeter EPTFE graft. Anastomoses sewn similarly with fine, non-absorbable suture. And the big one, strict sterile technique is absolutely paramount. It's a foreign body, so preventing infection is critical, more so than with autogenous tissue.
You mentioned EPTFE grafts. Are there different types? Does it matter which one is used?
While standard wall 6 millimeter EPTFE is common, there are variations. Thin-walled, stretch, ringed to prevent kinking, tapered, even heparin-coated grafts. But honestly, There's no strong evidence that any of these significantly improve long-term results compared to standard EPTFE. So the choice often boils down to surgeon preference and experience.
What about those early cannulation grafts? They sound useful.
They can be. They have a special 3-layer design. Allows needling much earlier than standard grafts, sometimes within 24 hours, though average is more like 2 to 15 days. Helpful if someone needs dialysis right now and a catheter isn't ideal.
But do they last longer?
Again, minimal evidence they offer better long-term outcomes than standard grafts allowed to heal for a few weeks, so remains a surgeon preference thing, situational.
The book also mentions cryopreserved conduits using veins or arteries from deceased donors. When would that be used?
Yeah, these are vessels harvested from donors, screened, preserved by freezing, usually a bore matched. They haven't shown great long-term patency in leg bypasses, but they seem relatively resistant to infection, so you might consider them for AV access if the patient has no usable native veins and is at high risk for infection with a synthetic graft. But patency isn't great, and there's a risk of developing antibodies, which could complicate a future kidney transplant, so definitely not a first choice.
And finally, the hero graft. Sounds specialized.
Very specialized. HERO stands for Hemodialysis Reliable Outflow. It's mainly for patients with blockages in their central veins subclavian, innominate stopping outflow from a normal arm access. It has 2 parts: a venous outflow catheter tunneled into a central vein above the blockage, and an arterial graft in the arm connected to that catheter externally. Reviews show pretty low primary patency, better secondary patency with interventions. Risks include steel infection. So it's really reserved as a last resort for those central venous occlusion cases when other options are gone.
Okay, so the access is placed successfully. What's the immediate post-op period like and the timeline for use?
Post-op is about close monitoring, bleeding, infection, blood flow signs. For autogenous fistulas, you're looking at maybe 12 weeks. Roughly, for full maturation before reliable use. Prosthetic grafts, much sooner, often usable as early as 2 weeks once the swelling's down. Early cannulation grafts, even sooner, as we said.
What if the fistula isn't maturing well, or a graft has early problems?
First step is usually duplex ultrasound. Assess flow, look for narrowing, clots. If that shows something, a venogram, the contrast x-ray might be needed to see the exact problem.
And if problems are found, can they be fixed to save the access?
Often, yes. There are secondary procedures, both open surgical and endovascular. Open options include things like vein patches, bypass grafts, transposing a segment, tying off problem branches, bringing a deep vein closer to the skin, superficialization. Endovascular means mainly balloon angioplasty, stretching open narrowed areas. Studies show that proactive monitoring and timely interventions really do salvage a lot of maturing or failing accesses, especially autogenous ones. Close follow-up makes a difference.
The book also mentions balloon-assisted maturation, BAM. What exactly is that?
Right, BAM. It's an endovascular technique specifically for fistulas where the vein is just diffusely small and not dilating well on its own. It involves doing repeated balloon angioplasties along the whole length of the vein, trying to stretch it open over time.
Kind of forcing it to mature.
Essentially, yeah. You can end up creating almost a collagen tube. Some studies show success in getting these fistulas functional, but the long-term results and the need for multiple procedures might end up being similar to a prosthetic graft. Plus, there are cost implications with repeated interventions. Some are even looking at using balloons at the time of initial surgery for tiny veins, but more data is needed there.
Okay, once an access is working well, patients on dialysis, what's the long-term follow-up involve?
This has actually changed. It used to be common practice to do routine surveillance measuring flow, pressures, maybe imaging, even if things seemed okay. But the newer KDOQI guidelines have moved away from that. They now recommend against routine surveillance without clinical indicators of a problem.
Really? So just rely on the physical exam?
The emphasis now is on regular, careful physical examination by someone experienced, a dialysis nurse, access coordinator, surgeon, looking for changes in the thrill, the bruit, difficulty needling, prolonged bleeding, swelling.
So, less preemptive fixing based on numbers, more fixing based on actual signs of trouble.
Exactly. Avoid routine interventions just because the surveillance number crossed some threshold. Instead, investigate further with a fistulogram and consider procedures only if the physical exam finds abnormalities suggesting a real problem.
Okay, finally the results. Long term, how do autogenous accesses really stack up against prosthetic grafts?
Well, first we need standard definitions. The SVS defined primary patency, works with no help. assisted primary, works with interventions but no failures, and secondary patency, total time usable, including after fixing failures. And functional access means getting good flow, usually 350-400 millimin, for adequate dialysis.
Got it. So how do they compare?
The data is pretty consistent. Autogenous AV accesses have superior primary and secondary patency compared to prosthetic grafts. The book gives ranges, but think 1 year primary patency maybe 43-85% for fistulas versus 40-54% for grafts. Similar advantages seen at 2 years and for secondary patency.
That's a clear difference.
It is. And while grafts can be kept going longer with interventions, secondary patency, they generally need significantly more procedures, angioplasties, clot removals than fistulas do to stay open. A big meta-analysis confirmed this better primary and secondary patency for autogenous at 6 and 18 months. Even the more complex basilic vein transpositions generally have acceptable 1-year patency rates, better than grafts usually. And using that 2-stage approach for smaller basilics gives comparable results.
But there's a trade-off, right? Didn't we say fistulas might fail more often right at the beginning?
That's the important counterpoint, yes. While fistulas last longer if they mature, they do have a higher rate of primary failure, meaning failure to mature adequately for use or early clotting. This might be partly because with fistula first, surgeons started trying to create them in patients with smaller, maybe less ideal veins, pushing the envelope a bit. One study even noted that more pre-op vein mapping seemed to correlate with lower functional maturation rates, maybe because it identified more challenging cases being attempted.
So bringing it all together, it's a really intricate area. Reliable hemodialysis access is absolutely vital for these patients, requires a highly individualized strategy. Autogenous is generally preferred for the long haul, if feasible. But so many factors go into finding that right access for the right patient at the right time.
Absolutely.
And it's clear that the field is constantly evolving, trying to improve outcomes, reduce catheter use.
Precisely. And that actually leads us to a final thought for you, the listener, to consider. Given all these advancements, surgical techniques, endovascular tools, understanding the biology, what new innovations might be on the horizon, what could further personalize and optimize access beyond just autogenous versus prosthetic? Could there be new materials, new biological approaches, new technologies to make this lifeline even more reliable, less burdensome for patients in the future? Something to think about.